And again, everybody, good evening.
Good evening.
Thank you. Welcome to our first program in North Carolina.
Thank you.
Thank you. And the reason why we brought this to you is we have been asked by many on social media, where we are very, very common, and Facebook, Twitter, LinkedIn, to provide educational programs. We've been doing this in Florida since February of 2010. Since February of 2010, MS Views and News has hosted more than 90 programs, mainly in the state of Florida. Last year, we did our first program in Atlanta, Georgia. We had 175 people attend our first program out of the state of Florida. That made us know we were needed to get out of the state. Last month, we did Birmingham, Alabama. We had over 110. Tonight, we're here. We have over 100. Okay, and next month we'll be back in Atlanta again, and then hopefully we can do this kind of tour again, getting out of state and including South Carolina in the second half of this year, and then going forward as well. And again, we cannot show that the pharmaceutical companies that this is needed unless we see this in the seminar evaluations. So we do appreciate everything that you do fill out. My name, again, Stuart Schlossman. Many people know me from social media, Blog Talk Radio, things that we're doing. Dr. Oz just named me one of 10 in the country for social media healthcare for multiple sclerosis. MS Views and News, again, we're providing all these educational programs. Why? Because there's a definitive need for education, information, and resources, and this is what we do. Unlike the other MS organizations, they all have their niche, and it's great what they are all doing, but this is, again, what we do, and we're going to continue doing this. Thank you. Tonight's program is made possible by Teva Neuroscience. We'd like to thank Teva Neuroscience, who makes Copaxone, and I want to thank them, and I hope you all do as well. Also, Questcor Pharmaceuticals, who makes the Acthar gel. You'll hear about these drugs from Dr. Jeffery. In addition to them, we have exhibitors of Accorda Therapeutics. They make Ampera. EMD Serono, who has Rebif and Novantrone, Biogen IDEC, Avanex, Tysabri, and Tecfidera, Genzyme for Aubagio, Novartis, Gilenya, and Crown Plaza. We have to thank them as well for working as hard as they did to make this room possible. Also, I want to thank all of our volunteers, and of course, I have to thank all of you for coming to tonight's program. And so I am, and MS Views, do thank all of you. Thank you. Tonight's program, we have Dr. Jeffery, who's going to introduce himself, and I'm sure many of you already know who he is. We also have Jessica Thomas from Winston. There we go. So they both came down the nice long drive through I-77 traffic to be here tonight, and I want to really greatly thank both of them for coming down to speak. Dr. Jeffery will be speaking for 50 minutes, 50. We ask that nobody ask any questions during his talk. If you feel you have something that you're going to want to ask later on, please write it down on the back of your hand if need be, all right? But just make sure that you wait with the questions. After Jessica speaks for 40 minutes, we're then going to do Q&A. We're going to run around the room. Me and Susie Phillips are going to run around the room with microphones. Again, you will not be video recorded, but we will hear your voice because those that are going to watch the program later on are going to hear what you're asking. If by chance somebody should shout out something before we get to you, whoever the question was for is going to repeat the question, but we do ask that you wait for us to get to you with a mic. We will try to be as efficient as possible. I need to lose weight. If you run me around the room, that's great. I will like that, all right? All right. Again, it's being video recorded, so again, we ask you to just, try to refrain on being overly loud with everything going on. Q&A, I already spoke about. Sorry, I'm repeating some of these things because I wrote some down and didn't write some down. Before I ask Dr. Jeffery to come up and speak, I have two support group leaders that are going to say something about their groups. One of them I got to bring this microphone to, and then Susie Phillips is going to speak. Jackie Blue is up first, and I got to bring her the mic. So excuse me, she's going to speak for a short moment.
Good evening. My name is Jackie Blue, and I'm a self-help group leader for Fayetteville, Cumberland County. Thank you. We have a transient population with the military there, so we have a support group that ebbs and flows. But now that I'm getting older, I'm finding out that the people around me are getting younger, and we have or will be trying to incorporate their children in our group. I'm shy, that's why I'm not on videotape, but I'm glad to be here. Thank you, Stuart. Bye.
Thank you. Yeah, you could say bye. It's all right. Next, we're going to have Susie Phillips for a brief 90 seconds, if she can hold it to that.
Can I put it here? I hate talking behind a microphone. I like freely walking around and talking to people. So bear with me. I am Susie Phillips, and I live in the Lake Norman area, and I run a support group for people, used to be for people with lupus, fibro, and MS. Now it is just MS. We meet the third Friday of every month at Davidson United Methodist Church. And at 10 o'clock till about whenever we leave. It usually lasts till about 11:30 or 12. Whenever you want to show up, whenever you want to leave is fine. I'm not a stickler like Stu is, okay? You said you want to have fun. So I just wanted to say thank y'all for coming. Thanks to Stuart for being here and doing this, because there's not a lot of people that do educational on all the A to Z for MS. So thank y'all.
Thank you, Susie. And thank you again for everybody. All right, so let's not hold up this program any longer. Dr. Jeffrey's got a long ride back and he wants to get started. So come on down. Price is right for you. Are you using this? Or?
Yeah. I'll probably take it out of there. It's hard to do, use both hands at the same time sometimes. Well, I want to thank you very much for inviting me to speak. And what I intend to do tonight is really to take you through the dynamics of MS, some of the epidemiology, and really talk to you about how this disease works and what are the mechanics of the disease. And then I'll take you through the drugs. So the first thing I want to point out is that right now my affiliation is at Cornerstone Healthcare. On July 1st, that's going to change. So I'm actually moving down to Lake Norman Neurology, and I will be working out of Mooresville and out of Huntersville. Now, for those of you who don't know me, I'm an MS specialist. That MS is all I do. I don't do anything else. I founded the MS Center at Wake Forest University back in 1994. Back at Wake Forest, we saw roughly 3,500 patients from all over the Southeast with MS. I'm involved in all of the clinical trials. In fact, I'm on the steering committee or the leadership committee for these clinical trials to actually help the drug company plan the clinical trials so as to be able to determine whether or not a drug will in fact work for multiple sclerosis. I'm involved in MS activities nearly every weekend and a lot of weeknights. So anything you want to ask about MS during the question and answer session, please feel free to ask, because I can probably give you an answer. But I will be moving down to this area, so I look forward to that in July. So basically, this is my first slide, and I like this because it says, what happened here, Sergeant? Placebo overdose, we're pretty sure he only thinks he's dead. And I always kind of enjoy that. All right. So then, let's take a look at an overview of MS. So a lot of the times you'll hear about estimates of the prevalence of MS being about 250 to 400,000 people in the United States. That's an enormous underestimate. There are probably over 1 million people in the United States alone who suffer from multiple sclerosis. This number of about 250 to 300,000 or 350,000 came from a study that was done back in 1994. In 1994, we had trouble diagnosing MS. We saw white spots on the MRI, and we weren't always sure what they meant. Now, it used to be that the average patient would go 5 to 10 years between symptom onset and diagnosis. Now, the average patient probably goes a year to a year and a half. So the diagnosis is made much more readily. The disease, of course, affects women much more often than men. The ratio is about 2 to 3 to 1. that ratio is actually increasing over time, as is the incidence of MS. And it's increasing in women faster than it is increasing in men. It's, of course, more common in northern climates, but in North Carolina here, in the central North Carolina region, our prevalence rate is about 70 per 100,000. It could be higher now. That number comes from a study that I did when I first arrived here back in 1994. The average age of onset is between 15 and 50. So 50 is not an old age for MS onset. In fact, I've had patients who had their first attack at the age of 3, and I've had other patients who had their first attack at the age of 65. So there's an enormous range. Generally, most patients will present between the ages of 15 and 50. It is also now the leading cause of disability in young adults in the United States today. So there's a whole variety of symptoms that occur in the context of MS, and actually I've learned more about the symptoms of MS from my patients than I ever did from any textbook. But of course there's fatigue. This is common. It occurs in 90%. One of the things I want to point out when we're talking about the symptoms is that there's actually 2 arms of treatment in MS. One is treating the symptoms. We can really improve your quality of life by adequately treating the symptoms. The second arm of treatment is actually the immunomodulatory therapy. Now, the goal of the immunomodulatory therapy, the ABCR and the oral medications, is to make sure that people don't get worse. So what my job description is as an MS neurologist is to make sure that when you're 90, you're as good as you are today. The good news is that we can actually accomplish that in the majority of patients we treat today. We have drugs which are highly effective and drugs which are much more tolerable than the drugs we've had in the past. So MS treatment has changed dramatically, but the most important thing I want to, and I'm going to emphasize this throughout the talk, is that you have to ask yourself how you're doing. Is there anything you could do a year ago that you can't do now? And if there is, that is a problem, okay? We don't want that. If you've had, relapses over the past year, or if there are any new lesions on the MRI scan, that is not something we're willing to accept. We have pretty much a zero tolerance approach. So going back to the symptoms, of course, spasticity is something bothersome for some people. Pain is very common. It occurs in 75% of patients at some point during the course of the disease. Loss of balance is a big one. People, when they trip, they can't really catch their balance, and they're much more likely to fall. Heat sensitivity, depression, weakness, sensory loss. Mood swings is actually very common. One of the things I ask most patients on their first visit is, the little things that never used to bother you really get you upset? And in about 60% of the time, that indeed is the case. And it's a very easily treatable symptom. Of course, tremor is common, sexual dysfunction, and cognitive deficits. Most patients will tell me that their memory just isn't quite what it used to be. They can't think of the word they want to use, and they have to write stuff down because they forget. And very troubling symptoms. And then, of course, there's constipation. So there's a whole variety of symptoms, but there are treatments for all of these symptoms. We can usually improve them if we try. Now, the next part, the allergies this time of the year are really terrible. I'm just getting killed with these things. So when people talk about MS, they often refer to MS as though it's an autoimmune disease. Well, MS, we don't know what causes MS. So it's not clear at all that MS is an autoimmune disease. In fact, there's a group of us MS specialists around the country, actually around the world, who really believe that MS is actually an infectious disease. What we do know about MS is that it affects people. So in order to get MS, you have to first have a genetic predisposition. If you don't have the genetic predisposition, you can try as hard as you want to get MS, and you can't get MS. If you have the genetic predisposition, then you're definitely at risk. So the way we know that excuse me, is that if you look at the general population, the risk of MS is usually about 1 in 1,000. Now, if you have somebody who shares 25% of your genetic makeup, the risk jumps up to about 1 in 100. If they share 50% of your genetic makeup, such as a son or a daughter, the risk goes as high as 1 in 20 to 1 in 60. Now, if you have an identical twin who has MS, the risk that the other identical twin will have MS is actually 1 in 3. So it becomes very high, but it's not 100%. So what we know is that genetic predisposition is there, but something in the environment has to weigh on that genetic predisposition. What that probably is a virus. And the most likely virus is a virus known as Epstein-Barr virus. That's the virus which causes infectious mononucleosis. So if somebody has infectious mononucleosis as a teenager, the risk of having MS is 5 times greater than that in the general population. If somebody has not been exposed to the Epstein-Barr virus, their odds ratio for having MS is actually 0. Okay, so having Epstein-Barr virus is actually a prerequisite to getting MS. That being said, we can't find Epstein-Barr virus in the brains of patients who die with MS, so we can't prove that it's Epstein-Barr virus, and it may not be. It may be that Epstein-Barr virus sets you up for some other event to take place, which then results in MS. The long and the short of it, and I can talk a lot more about this etiology, it's really pretty interesting, is that we don't know what causes MS. So we really can't say for sure that MS is an autoimmune disease. We know that MS is an inflammatory demyelinating disease, but we can't say that it's autoimmune, and we can't say for sure that it's infectious. So just the information. Now, if we look at the general population with MS, at any one time, about 55% are going to be relapsing remitting, 31% will be secondary progressive, and then about 14% are going to be what we call primary progressive. Now, the patients who start out with relapsing remitting MS can transition to secondary progressive MS. The patients who start out with primary progressive MS will always have primary progressive MS. Primary progressive MS is defined as a form of MS in which there's a slow, gradual deterioration with or without ever having had a superimposed relapse. Now, the problem with primary progressive MS is that we have no approved drugs that are known to work in primary progressive MS. That doesn't mean that we don't try to treat it. Even if somebody has primary progressive MS, we still try to treat them, and my job description is still the same, to make sure that when that person's 90, they're as good as they are today. I want to point out that it's also the most misdiagnosed entity in the field of MS. So I've had lots of patients come up to me and said, I was diagnosed with primary progressive MS. And I said, well, how did you start out? And they say, well, I had an optic neuritis. By definition, that's not primary progressive MS, because that optic neuritis is an MS attack. So always important to remember that. Now, about 85% of the patients will start out with relapsing remitting MS. Once again, about 15% start out as primary progressive MS. Now, in the absence of effective treatment, patients will transition to secondary progressive MS in the majority of the time. So this is actually a graph which shows the natural history of MS, and let me take you through this. So what you're looking at here, this green line is cerebral brain volume. This purple line is the clinical course, and these bars, those are relapses. This red line is the burden of plaque that we see on a T2-weighted MRI. And I'll show you an MRI that shows plaque, and it shows you the difference between an active lesion. Now, these yellow arrows, these are what we call silent explosions, or they're actually gadolinium-enhancing lesions. So when your doctor puts you in the MRI scan and they give you that injection of contrast dye, the contrast dye is taken up into areas of the brain in which there's active inflammation. Now remember, that active inflammation is doing damage to the nervous system. That's what's stripping the myelin and damaging the nerves. Now, when these lesions occur in the periventricular white matter, they don't cause any motor or sensory symptoms. They're essentially silent. So we refer to those as silent explosions. When they occur in the optic nerve, that's when you get an optic neuritis. If they occur in the spinal cord, that's when you have weakness and numbness in your lower extremities. So the lesions that you see on the brain MRI, really they're associated with cognitive dysfunction, but they don't have any effect on motor or sensory function. The lesions that do that are in the spinal cord, and that's what causes weakness in your legs, and that's what causes the numbness, okay? So the way patients start out is they start to have these silent explosions on their MRI, and then they don't really have anything happen. But during this preclinical phase, they don't really feel very good. Most patients start to have fatigue and problems with their memory, and they just don't feel good, okay? Then what happens is eventually one of these silent explosions strikes in a strategic location, such as the optic nerve or the spinal cord, and then the patient has their first attack. And then they get better from the attack, But then in between the attacks, they continue to have a high frequency of the silent explosions. So in fact, the average patient will have 5 to 10 new lesions for every clinical attack that they experience. This goes on over time, and eventually the plaque accumulates and the patient hits the secondary progressive phase. And once again, that's defined as a gradual deterioration with or without superimposed relapses. And then the disability increases over time, brain volume shrinks, and the lesion burden goes up. And then later on in the disease, in the late secondary progressive phase, the frequency of the silent explosions actually decreases over time. And that's what occurs in the absence of treatment. Now, if we go back to the days before we had any treatment for MS, and we look at disability progression in the entire MS patient population, we find that disability progresses rather slow. So this DSS of 6 stands for a disability status score. And a 6 means that you need a cane to get around. You need a unilateral ambulatory assistance. So what this tells us is that the average patient in the absence of treatment requires about 15 years before they need a cane to get around. So some patients move faster, other patients move slower. What happens in MS is that in the absence of treatment, patients transition from relapsing remitting to secondary progressive MS. So if we look after about 5 years, 12% of patients have become secondary progressive. After 15 years, untreated, about 60% of patients are secondary progressive. And after 26 years, roughly 90% of patients have transitioned to secondary progressive MS. Now, that's really depressing. But with effective therapy, that need not be the case. So in studies with our older agents, the interferons, what we were able to demonstrate is that the patients who were on treatment had markedly decreased rates of transition to secondary progressive MS. Now we have even more effective treatments than what we've had in the past. So once again, our object is to make sure that when you're 90, you're as good as you are today. We don't want you ever to become secondary progressive. And what that means is that we need to have you on very effective therapies. And we need to monitor you and make sure you're not having new lesions on the MRI and they're not having breakthrough lesions and that you're not having any worsening. So what happens when people get to the secondary progressive phase, the disability progression moves a lot faster, and people go from 0 to a DSS of 6 between 4.5 and 2.25 years. So once people hit the secondary progressive phase, the disability progression really goes much, much quicker. So now, when we come back here, what I'm going to show you again, remember the yellow arrows are the silent explosions, and the red line is the fixed plaque. So now I'm going to show you what that actually looks like on an MRI. So this is a silent explosion. Here's a patient who had an MRI scan with contrast, and you see this little white area up there? That's a silent explosion. Okay, so what's going on in that portion of the brain is that there's actually edema, demyelination, infiltration of lymphocytes and macrophages or immune cells into the nervous system with myelin transection or myelin stripping and actually transection of the axons. Okay? So those are pathologically important events. So if somebody has this on the MRI, even if they're not having any symptoms, what that tells me is that there's ongoing damage to their central nervous system. So what you're looking at here, this is a fixed plaque. So what happens after this lesion goes away, this inflammation will last only about 3 or 4 weeks. But when that inflammation goes away, it leaves a scar. And so you can see this scar on the MRI. And that's what we refer to as a fixed plaque. Now, what happens, let's say the patient has one of these silent explosions, only that silent explosion hits in a different location. Let's say it hits in the spinal cord. And then you get a lesion that looks like that. And that's the single lesion that can put you in a wheelchair. So that's why it's so important to obtain a complete shutdown of all new lesions on the MRI. We never know when one is going to hit in a strategic location. And if somebody is having ongoing lesions, even if they don't feel bad, even if they're not having new symptoms, it's just a matter of time until that lesion hits in a strategic location. So for my patients, I want them on the most effective therapy with the least possible risk. And there's always a benefit with all of the treatments that we talk about between benefit and risk. Okay? So now, what's changed in the field of MS, which is so great, is that we have so many effective therapies. So it used to be we just had Avonex, Betaseron, Copaxone, and Rebif. Those were the days of the injectables. Then in 2010, Gilenya came along. Extavia is exactly the same thing as Betaseron. So they're made in the same factory. One bottle comes off and gets a Betaseron label. The next one comes off and gets an Extavia label. So they're exactly the same thing. No difference. Then we have, of course, Gilenya. Tecfidera has been around a little over a year. Aubagio, maybe a year and a half. We now have Tysabri, which is a highly effective therapy. And we have Copaxone 40 milligrams 3 times weekly. So all of these medications are good medications. They're all effective. They're not all the same. So let me take you through and talk about each one of these medications. So Gilenya. Gilenya is an effective medication. It decreased relapse rates by an average of about 74%. In terms of the fixed plaque on MRI scan, the new punctate T2 lesions were decreased by 74%. So that was a very robust effect. Gadolinium-enhancing lesions, or in other words, the silent explosions, they were decreased by 82%. There was a 30% reduction in the progression of disability, and it also decreased the loss of brain volume by about 30%. Now, the next thing I'm going to tell you is that for any drug that we talk about, remember when we enroll patients in a clinical trial, which is where these numbers are coming from, we're enrolling patients with really bad MS, and we're enrolling patients with really mild MS. So there's a spectrum of severity. And we think about it on a bell-shaped curve. So on the right-hand side are the patients with really aggressive disease. On the left-hand side are patients with much milder disease. So when we talk about this number, this 54%, that's the person right in the center of the distribution. So what that means is that the people on the right-hand side of the bell-shaped curve maybe didn't do as well, and the people on the left-hand side of the bell-shaped curve probably did a lot better. Okay? So this is, again, the person in the center of the distribution. So I hope I'm being clear on that. I hope you're not misunderstanding that. So then with Gilenya, the side effects associated with Gilenya usually include headache, fatigue, back pain, and diarrhea. But the experience in clinical practice is that the majority of patients come back and say, I'm not having any of that stuff you told me about, and I think this is great because I'm not taking a shot, and I can't tell that I'm taking anything. And that's usually what you hear. Some patients, as with any drug, will have side effects. Now, Gilenya, some people have worried about it. It can increase your liver function test, but it does so rarely, much less than it did with the interferons. It can increase your risk of flu and bronchitis, but only by a tiny bit. So if in this study, in the placebo group, 9% of the patients got the flu. In the treated group, it was 12%. You're kind of going big deal. With bronchitis, it was 6% in the placebo group and 10% in the treated group. So there really wasn't a big increased risk. In the point of fact, I can't tell that my patients on Gilenya are getting infections more often than anybody else. It also can cause macular edema. That's the swelling behind the eye that can be associated with loss of vision. In general, the risk is between about 1 in 250 and 1 in 500. If somebody is diabetic, they're at much higher risk for macular edema. And if they've had a prior history of something known as uveitis, they also have an increased risk of macular edema. Now, Gilenya, I think, is a very good medication. Sometimes it's a little bit of a hurdle to get the medication started because you have to do a first dose observation. So I think what many patients have heard is that there are cardiac side effects with Gilenya. And, that's not really, yes and no. So when you give the first dose, the average patient will drop their heart rate between 8 and 13 beats a minute. That occurs only on the first day. But when the FDA looked at it, they said, well, we would feel more comfortable if patients had their first dose in a monitored clinical setting. You don't see the effect on day 2, and the reason you don't see it is because Gilenya binds to receptors which are called S1P receptors. So when the Gilenya binds to the receptor gets internalized into the cell. And then on day 2, when they take their next dose of Gilenya, the receptor's not there anymore. Okay, so their heart rate doesn't slow. So that's all it does. It causes a first dose slowing of the heart rate, and that's it. So it's basically a trivial thing. And so when we bring patients in for their first dose of Gilenya, we check their heart rate and blood pressure every hour for 6 hours, and then we let them go home, and that's it. It's very easy. Finally, with all of the new oral agents, in the days of yesteryear when we had patients on Avonex, Betaseron, Rebif, or Copaxone, if they got pregnant on drug, we simply stopped the drug and everything was fine. There was no increased risk of harm to the baby. But with the new oral agents, we don't have that information. And in some situations, we know that that's not the case. That is the case with Gilenya. Gilenya readily crosses the placental barrier and it binds to receptors which are involved in genesis of the vascular system. So basically, there have been reported cardiac malformations in children born to moms who conceived while on Gilenya. If a woman is on Gilenya and they get pregnant, you can't wash out Gilenya any faster than it normally takes to leave the system. So that takes about 2 months. And so if somebody gets pregnant on Gilenya, that drug is going to be there during the entire time of organogenesis. So I warn my women of childbearing age, I absolutely do not want you getting pregnant on Gilenya or any other of the oral medications. Because with some of them we know this is bad news. With others, we just don't know. But we don't want to take that risk. So if we're using any of the oral medications, I usually prefer that my women of childbearing potential have IUDs in place. And the reason being, birth control pills are only 92% effective in preventing pregnancy, whereas an IUD is 99% effective. So I would prefer to have that extra margin of safety. But that being said, as long as people understand and they're aware of it, even if you're a woman of childbearing age, there's no problem with being on Gilenya. You just want to make darn sure you don't get pregnant on it. Okay? The next new one, is Tecfidera. So Tecfidera has been around about a year, a very good medication. Tecfidera is a twice-daily oral medication. It reduced relapses between 44 and 53%. It reduced new T2 lesions by about 71%. I should point out there are 4 arms in the clinical trial. One of the arms of the clinical trial did substantially better, but the other 3 arms, the average reduction in new T2 lesions was 71%, and in gadolinium-enhancing lesions or silent explosions was about 76%. It did reduce disability progression in one study, but not the other. In other words, it actually reduced them in both, but the numbers ranged from 23% to 30%, 38% decrease in disability progression. And in one study, brain volume was favorably affected, but that wasn't seen in the other study. Nevertheless, a very good drug. Its efficacy, I think, is quite good. It's as good as Gilenya. I wouldn't say it's better. I wouldn't say that one of these oral agents is necessarily more effective than the other oral agent. So, what we do now is when we're talking to you and deciding which oral agent we want to use, we, explore all of the oral agents and decide which one is going to be the best one for you in particular. And it's never, there's no one agent that's perfect for everybody. Now, one of the great things about Tecfidera is the safety profile was wonderful. So they really didn't see any increase in risk of infection. They didn't see any significant safety adverse events. We don't know much about pregnancy. There have been very few women who have become pregnant while on Tecfidera, so we just don't know. There's no reason to think that it would have an adverse effect on the developing embryo, but we just don't know. So what I'm going to tell you is if you're on this medication, I do not want you to become pregnant. It also decreases the lymphocyte counts, but in a drug known as monomethyl fumarate, which is available in Europe, if you do a very careful, deep depth review of the safety literature on monomethyl fumarate, let me explain that Tecfidera is metabolized into monomethyl fumarate, you find absolutely nothing. You can't find any reports of adverse safety events in patients on that drug. There's just nothing there. So I have great confidence that this drug has a really, really good safety profile. Now, one of the things that happens with Tecfidera is that if I start 5 patients on Tecfidera, 4 of them are going to come back and they say, this stuff is great, I'm not having any of those side effects you told me about, and I love this stuff. And the 5th patient's going to come back, or they're going to call me after a week and say, look, I've been in the bathroom all week and I'm just not taking it anymore. Some patients can actually get through the side effects. The side effects can include flushing, itching, nausea, diarrhea, and abdominal pain. For the majority of patients, they come back and they don't have this, or they come back and it's manageable and they can get through those side effects. There's a small proportion of patients who come back and say, boy, I just can't take this stuff. And that's true with any of the drugs. There was a recent paper at the Academy of Neurology meeting showing that a drug, an asthma drug called Singulair, markedly decreased the frequency of GI side effects. So now I've started giving a couple of patients today Singulair to try to make their side effects better. And from what I saw at the Academy meeting in this one paper that was presented, this really seems to work. So that's a little tidbit that may be of use. So then the next new oral agent is Aubagio. Now, when we looked at Aubagio in the clinical trials, it decreased relapse rates by only 31%. But when you look at the absolute difference between 31% with Aubagio and 53 or 54% with Tecfidera and Gilenya, it turns out that that's accounted for by 0.1 relapses a year. Okay, or 1 relapse every 10 years. So now in our clinical trials, the baseline relapse rates are so low that a really tiny change in the relapse rate makes up this really big percentage. So when you look at the effect of the drug on the MRI parameters, it's every bit as good as Gilenya and Tecfidera. So it decreased new T2 lesions by 70%. Remember, Gilenya was 74%, Tecfidera was 71%. That's basically the same number. It decreased silent explosions by 80%. The number for Gilenya was 82%. The number for Tecfidera was 76%. So those are the same number. Decreased disability progression, 30%, and it affected white matter volume loss. So basically, when you look at this drug, you're saying, hey, this is every bit as effective as the other oral agents. And it's true. It is every bit as effective as the other oral agents. I wouldn't tell you that one of the oral agents is better than the others. Okay. Now, in terms of side effects and tolerability, Aubagio, patients experienced a little bit of transient nausea and diarrhea. Most patients came back and said, you know, I haven't had any of that stuff, and I love it. I feel great because I'm not taking a shot, and I can't tell that I'm taking any medication at all. This is fantastic. It can cause some hair thinning. This only occurs in 1 out of 10 patients. It's usually mild, and it's usually pretty transient. And it goes on for maybe a month or 2 and then resolves completely. The drug does have a warning for liver function test elevations, and that's really undeserved. So the way that warning got in there is Aubagio is actually the metabolite of a parent compound which is known as Arava. And Arava was used in rheumatoid arthritis, and when it was used in rheumatoid arthritis, it was always used in conjunction with a drug known as methotrexate. Methotrexate is known to be liver toxic. So the FDA looked at the experience with the older drug, Arava, used in conjunction with methotrexate, and it said, wait, you saw liver toxicity in that clinical setting, and even though you didn't see liver toxicity in your clinical trial, we're going to put that in your label because we saw it in this older clinical setting. So the warning is in there, but it's really not deserved. In point of fact, I've had very few patients come back with even minimal elevations of their liver function tests on Aubagio. It just has not been an issue. Now, one of the other issues with Aubagio is there is a pregnancy, it carries a warning for pregnancy. So it's a pregnancy category X, and that's because they saw fetal malformations in animal studies. So when in mice, when the female mice got pregnant while on Aubagio, there were some fetal malformations. This has not really been seen in the human experience, and if somebody does get pregnant on Aubagio, you can actually do a rapid elimination procedure. So basically the incidence of spontaneous abortions or other adverse pregnancy outcomes has been no higher in patients who got pregnant on Aubagio than it has been in the general population. That being said, we know there's a risk, so we really don't want anybody to get pregnant on Aubagio. If they do get pregnant on Aubagio, we can do a rapid washout, okay? But we really don't want them to become pregnant. So in summary, Aubagio is another very good medicine. And in this day and age, what we've also started to do, in most of the MS centers you'll find, when I have a newly diagnosed patient, I don't want you to put you on injections. I put thousands and thousands of patients on injections for years. And now that we have effective oral agents, there are situations where we may still want to turn to one of the old injectable agents, but for the most part, we're using the oral agents more and more because it's tolerable, it's easy to do, and who wants to take an injection if you don't have to? And these are good medications with excellent safety profiles and very good tolerability profiles. That being said, if we go back to the older medications for just a minute, I want to take my hats off to the companies. For example, Bayer and Serono, who made Betaseron and Rebif, and they're still around and still in use, but they revolutionized the way we treat MS. So back in the day when we first got our effective therapies, it really changed the outcome of MS for really a lot of people. And people have done so much better since these therapies have been available. It's just a night and day difference. If you went to an MS clinic in the early 1990s, most of the patients were sitting in a wheelchair. Now, most of the patients are walking into the clinic. So, very big difference. So now, let me take you to Tysabri. Tysabri is one of the medications I like the most. And the reason I like it the most is because Tysabri has superior efficacy. It is also more dangerous, but not for everybody. So let me take you through that and explain it. So if we look in the general population, Tysabri decreased relapse rates by 67%. It decreased new T2 lesions or new plaque by 83%. New silent explosions were decreased by 92%, and disability progression was decreased by 42%. It did not affect brain volume loss, but I think that's probably due to methodological problems with the way they did brain volume loss in that study. I don't think that's the real effect. So in other words, when you look at Tysabri and compare it to what we see with the other medications, Tysabri really does appear to be more effective. And we adopted Tysabri as a rescue therapy. That's where we use it. So one of the big problems with Tysabri is we know about this disease state called PML. That stands for progressive multifocal leukoencephalopathy. It's a deadly brain infection that's caused by a virus known as the JC virus. So this is what really limited the use of Tysabri for a while. Tysabri was first introduced onto the market in 2003, November of 2003. And then it was removed from, or November 2004, in November of 2004. Then it was taken off the market in March of 2005 when it was found that 3 cases of PML were discovered with Tysabri. 2 of them occurred in the MS clinical trials, and 1 occurred in the clinical trials for Crohn's disease. Then it remained off the market until about July of 2006, and it was reintroduced on the market with the understanding that its efficacy was superior and that it could be used as a rescue therapy. And that's why Tysabri got put back on the market. Since that time, Biogen, the company that makes the drug, has really done an outstanding job of helping us determine who we can use this drug in safely and who we can not use the drug in safely. Because PML is a very deadly disease. The mortality rate is about 25%, and even though 75% survive the infection, 90% of those patients are left with moderate or severe disability. So this is a deadly serious event. I've taken care of 3 patients who got PML. I don't ever want to see the disease again. So now, with a test known as the JC virus antibody test, we can actually determine who is safe to use the drug in and who the drug is not safe to use the drug in. I will also tell you that the risk of PML is very much dependent upon time. Let me go to the next slide. So this is actually tells us about the JC virus antibody test, and I'll come back to the PML risk because it really depends on how long somebody is on Tysabri, and that's very, very important. And the reason it's so important is because we have patients who are going downhill and going downhill rapidly, and they may be JC virus positive, so they're afraid to go on Tysabri because they think that they're at high risk for the brain infection right away. That is not true, okay? So I'm going to come back to that in a minute. So the JC virus antibody test, initially we just had people we just had either positive or negative. Now we have something known as a JC virus index. If people are negative for the JC virus, it doesn't really mean that they haven't been exposed, but it means that their risk of PML is exceedingly low. So this is a statistical calculation where they said, let's say if you had one theoretical patient who was JC virus negative and got PML, what would the risk be? And they said it would be 0.07 per thousand, or about 1 in 14,000. In fact, if somebody tests negative for JC virus antibody, it means that their risk of PML is essentially zero. It's negligible. So in patients who are newly diagnosed, I now have this drug which is highly effective, better than any other drug we have. And it keeps people stable, relapse-free, free of new MRI lesions. Why would I ever use a less effective therapy if I have no risk of the brain infection? So in fact, we do that. If people are JC virus antibody negative, I will use this drug as a first-line agent for newly diagnosed relapsing remitting patients. Now, if they're JC virus positive, then they have a risk of PML, and that risk is dependent upon time. So during the first year of therapy in a JC virus positive patient, the risk is about 1 in 40,000, okay? At 1 in 40,000, I know my patient's not going to be the one. If they're between year 1 and year 2, the risk goes up to about 1 in 2,000. At 1 in 2,000, I'm still pretty darn sure that my patient's not going to be the one. The problem is at year 3, the risk goes up to 1 in 220. At 1 in 220, I'm not going there. If I stay with more favorable odds, like 1 in 40,000 or 1 in 2,000, I'm never going to see PML. But if I start treating patients whose risk is 1 in 200, then I'm going to see PML. Okay, and I don't want that. So that's where I won't use the drug. But what that means is that you can use the drug in a JC virus positive patient safely for 2 years. Now, that brings us to an interesting point where we are now. We're going to have a new drug in January of 2016, and I'm going to talk a little bit about that later on. That new drug is called ocrelizumab, and ocrelizumab looks to be every bit as effective as Tysabri, if not maybe more effective than Tysabri, and that's going to be available in 2 years. So now, if I have somebody who's really feeling pretty crummy or not really doing very well, I can use Tysabri as a bridge until we get to ocrelizumab. Now, the one thing I haven't told you about Tysabri, which I probably should have said when I talked about its efficacy, is that one of the great things about Tysabri is that it's the only drug that I have when I put somebody on it, I fully expect that when they come back, they're going to be better than they were before I put them on it. So we have post hoc studies that looked at the clinical trial results that demonstrated that 70% of patients who went on Tysabri had sustained clinical improvement. Not everybody, but 70%. And once again, about 70 to 75% of patients who go on Tysabri come back and tell me that they feel better, they can do more, their endurance is better, their wives tell me that they're actually walking better, they tell me that they have more energy and their mental fogginess is better. So, boy, you know, when I have a drug that does that, boy, I really like when I can put somebody on it because that makes my day. So now, when we go back to this JC virus index, so now with the more recent test, what we have is this JC virus index, and it tells us how positive it is. So a low index is between 0 and 0.9, or actually 0.4. Below 0.4 is negative, 0.4 to 0.9 is low index. So what this means, if somebody's low index, actually under 1.5, that means that under 2 years of treatment, rather than the risk of 1 in 2,000, their risk is less than 1 in 10,000. okay? And so if somebody's index is less than 1.5, I can use Tysabri quite safely for 2 years. Now, over 2 years, that's when the risk increases. So if they're really low index, below less than 0.9, the risk after 2 years is 0.3 per thousand, or roughly 1 in 3,300. That's still pretty safe. But as that JC virus index goes up, after 2 years, you start getting into progressively greater risk. So if their index is 1.3, over 2 years, their risk is about 1 in 1,000. If their risk is greater than 1.5, then over 2 years, their risk is about 130, 1 in 130. So that's where I don't want to use Tysabri, because that's just too dangerous, okay? So overall, this just shows you the risks. This is month 1 to 24, JC virus antibody negative. Basically, the risk is essentially 0 throughout the entire time of treatment. If they're JC virus positive, less than 0.9, we can generally use it safely after 2 years. But if their risk is greater than 0.9, under 2 years, the risk is roughly 1 in 1,200, and over 2 years, the risk is about 1 in 140. Okay, so that's how we decide whether or not we can use Tysabri safely, and that's how we do it. So now, Copaxone 40 milligrams 3 times weekly was just introduced, very recently approved by the FDA. Copaxone, as you know, has a great safety profile. Its side effect and tolerability profile is excellent. Copaxone 40 milligrams 3 times weekly decreased relapse rates by about 36%. It decreased new T2 lesions by 35%, decreased gadolinium-enhancing lesions by 44%. Now, they didn't show an effect on disability progression because it was a 1-year study. And all the other studies are 2 years, and it takes time to see disability progression in a population of patients. So we really didn't expect to see an effect on disability over a 1-year period of time. And once again, no new side effects were reported. What was seen was injection site reactions, immediate post-injection reaction, and there are no serious safety considerations with Copaxone. So Copaxone has served us very well for a very long time. Now we have 40 milligrams 3 times weekly, so that's also an option. So now, once again, coming back to this, what I want you to be thinking about and always thinking about in the past year, how many relapses have you had? If you've had 1 with complete recovery, we would say that's notable. If you've had 2, even with complete recovery, I don't like that one bit. If you've had 3 relapses, that's too many, and we're going to switch your therapy. Conversely, if you've had 1 relapse in a year and you had incomplete recovery, by definition, you have had disability progression, and that is not acceptable. So you also have to look at where you're at. So I tell groups of the physicians this, but I don't often tell groups of patients. If somebody develops a fixed neurologic deficit, saying they're in their mid-30s or mid-40s, and let's say they have weakness in one leg, what that tells me is that unless I do something differently 10 years from now, they're probably not going to be walking, okay? So if we see that happen, boy, we want to really take some action, because if we take action, we can prevent progression. So one of the interesting things now is we can take patients with very aggressive disease and we can shut it down. Okay, so even the patients who 20 years ago I would have looked at and said, oh my God, I don't know what we're going to do. Now I know exactly what we're going to do. So we can shut it down. And if we see new lesions on the MRI scan, even a single new lesion on the MRI scan predicts disability progression over a period of about 2 to 3 years. So every year when you get your MRI, look at your MRI, compare the one on the left, which is last year's, to the one on the right, which is this year's, and I want to know if there's any new lesions. Now, early on in the disease, it's important to do that every year for the first few years. Once somebody's been stable and hasn't shown new lesions for 2 or 3 years, then you can back off and do it once every 2 or 3 years. If somebody's had MS for 15 years, then it really doesn't help you very much unless there's been a clinical change, okay? And so that's really the way we do it. So now, what are the drugs that's coming? There's alemtuzumab, which has been resubmitted to the FDA, Plegridy, which is low-frequency high-dose interferon, daclizumab, ocrelizumab, and ofatumumab. So I've got 3 minutes and 26 seconds left, so I'm going to try to get through this pretty quickly. Alemtuzumab. This is a very effective drug. that's given 5 days in the first year and 3 days in the second year. It was studied in 2 head-to-head clinical trials against Rebif. It decreased relapse rates by 55% using Rebif, a very effective medication, as the active comparator. Disability progression was less than that seen in Rebif in one trial, but equal in the other trial. The MRI effects were not all that much greater than that was seen with Rebif. One of the problems with alemtuzumab, it is a highly effective therapy, but it has a lot more safety issues. So it's an immunosuppressive agent. So for the first 2 months after people are treated with the agent, their lymphocyte counts are 0 and they have to be on antiviral therapies. Then, over a period of about 4 years, 36% developed autoimmune thyroiditis, 2 to 3% developed ITP, which stands for immune-mediated thrombotic thrombocytopenic purpura. That's an autoimmune disorder in the blood where you make antibodies against platelets and it can cause bleeding. It can be very dangerous. About 0.3% developed something known as Goodpasture syndrome, and that's an autoimmune disorder of the kidneys, and that can require kidney transplant, and it carries a fairly high case mortality rate. It can also cause other autoimmune diseases like autoimmune hemolytic anemia, and it can have permanent effects on the immune system. So once you've used alemtuzumab, you can't take it back. Okay, so this is right now in front of the FDA, and this may be appropriate for some patients. I think it should be on the market, but I think its use is going to be pretty limited to patients who have very high JC virus antibody levels, who have had a very aggressive disease, and then it may be an option. But this is a very serious drug. It is a highly effective drug, but a very serious drug with really some very serious potential toxicities. The next new drug that's going to come out is Plegridy. So Plegridy is actually a pegylated interferon, and it allows the interferon to last a lot longer. So it's an injection once every 2 weeks, and it's every bit as good as Rebif or Betaseron. It decreased relapses by 36%. New T2 lesions or new plaques were decreased by 67%. Silent explosions decreased by 86%. It's a high-dose, low-frequency interferon. It'll have the same side effects as Betaseron or Rebif, or Avonex for that matter. The next one, which is going to be probably sometime in 2016, is daclizumab, and this is a monoclonal antibody against CD25. It's actually given as a subcutaneous injection once every 2 weeks. It decreased relapses by 54%. Here's the real sort of trigger for this one, or the one that may make this more attractive, and we don't have the full story yet. It decreased new T2 lesions 70% the first year, but then by 90% the second year. So when we look at that threshold of decreasing new T2 lesions, right now the best we've been able to do is 83% with Tysabri. So now this drug looked like it was better in year 2 than in year 1, decreasing new T2 lesions by 90% in year 2. So that has the potential to really, if that turns out to be true in subsequent studies, that really has some potential to say that, okay, this drug may be better than Tysabri. The safety profile is pretty good. It can cause some cutaneous side effects, but I'm running out of time to talk about that. And decreased disability progression by 50%, but we'll see if that's borne out in subsequent clinical trials. The next one, and I'm going to wind up, I think, with this slide because I'm already out of time. This is ocrelizumab. This is coming in 2016. Probably the first portion of the year. This is a monoclonal antibody that kills a type of lymphocyte known as a B lymphocyte. It has very high efficacy. In the first 6 months of the clinical trial, it decreased relapse rates by 80%. And then it decreased new lesions by 97%. That was in the first 6 months. Then they did an open label follow-up study where they took all the patients who were on placebo and the high dose, and they put them all on a single dose of ocrelizumab. Over the next 2 years, in over 200 patients, there were only 2 patients out of 200 who had new lesions on their MRI. And so that sort of blows us out of the ballpark. I mean, that takes us to a whole level of efficacy which we've never seen before, and it has a very good safety profile. So this is a drug that's now coming in January of 2016, roughly a little over a year and a half from now, okay? And so now we can use Tysabri as a bridge until we get to ocrelizumab. Okay, so that allows us a window of opportunity to, if somebody's really not feeling well or really not doing as well as we like them to do, you know, even with a JC virus index of over 1.5, we can take them on Tysabri for a year and a half and then switch them to the new drug. Okay, so that's also changing the way we do things. So in summary, and I hope I haven't gone too far over, we have a lot of really new agents. Some of these are highly effective. They'll be here soon. Well, again, we're going to be able to treat MS more effectively than we've ever been before in history. So we're a whole new era. And so basically, to wind up, if you're having relapses, new MRI lesions, or if there's anything that you could do before that you can't do now, we need to think about changing your therapy, okay? So I'm going to end there, and I think I'm out of time. Stuart's coming up. He's going to take the microphone, so give me that. You're out of time. But I've been through a lot of information, and I hope it's been helpful.
Thank you. You have questions? Just say your question, and between the two speakers, they'll figure out who's to answer, okay? Because I'm not going to ask you each one. Who's got a question? Let's start. Okay, we'll start right here.
We're just cracking jokes over here.
I know.
We're not very good.
Question for you is, if you've been on Tysabri for 2.5 years, how long after coming off of it do you still need to worry about PML?
Once you've been off it for 2 months, you're free and clear.
So even if you take other medicines?
Pardon me?
Oh, no. Even if you take other medicines?
Even if you take other medicines? Yeah, even if you're on other medications. So once you've been off Tysabri for 2 months, basically lymphocyte trafficking is restored, and if you don't have PML within 2 months after going off it, you're not going to get PML. Now, the other thing you can do, so let's say somebody's on Tysabri and you know their JC virus index is up there and they're positive. They can go off it for 6 months, and then after a period of about 6 months, they can probably go back on it with a greatly reduced risk. Now, we don't know that to be fact. That's something that's more of my opinion. So before we had the JC virus index, we would do something known as a drug holiday. So we would treat for 2 years, and then we would take people off for 6 months, and then go back to it for another year to a year and a half.
Okay, I thought I heard them say they have a question. All right, we're gonna go back and forth. Susie, then me, then Susie, then me. Blah blah. Go.
How is the how do you pronounce it? It was the last acrelizumab.
Oh, ocrelizumab.
How do you take that?
It's an IV that's given once every 6 months.
Okay.
So, you know, that's not having to do much. That's not too bad.
All right, who's next over here? Okay.
I was wondering, Dr. Jeffery, if you could explain a little bit about the actual JC virus, like if you don't test positive, if you don't test positive, you test negative, but there's that chance that you can possibly contract it. How does that work?
So let me explain the test. So a negative JC virus test doesn't actually mean that you haven't been exposed to the virus. It's really very interesting. If you look at a type of blood cell in the body, what's called a T cell, T cells are very specific for acquired pathogens. So in 80% of the population, we can detect JC virus specific T cell responses. So what that means is that 80% of us have actually been exposed to the JC virus. But if you look in the general population, what you find is that only about 50 to 55% of people have the antibody. Well, if somebody doesn't have the antibody, it doesn't really mean that they haven't been exposed. What it does mean is that their immune system handles the virus so adroitly that they don't need an antibody response. And it means that those people, their immune system, it just completely keeps that virus under control. So we know that their risk is essentially zero. So that's really what the JC virus test means.
Got a question here? Hold it close.
With the, I'm going to call it the Oprah drug. I noticed that. Yeah. I didn't notice if it was anything to do with restoring any damage that MSS drugs.
So none of the drugs that we have right now are known to restore function. So that's not how they work, but they do. Okay, so how does that happen? So Tysabri, it doesn't do anything other than prevent lymphocytes from going from the periphery into the central nervous system. So why do people get better? The reason people get better is because it so effectively suppresses inflammation that the reparative mechanisms in the nervous system can work much more effectively. So you actually see people improve. Okay, so we believe that will be the case with ocrelizumab. We actually saw that with Novantrone back in the days when we used to use Novantrone, and you notice that I left it off my slide because we don't use it anymore because it's too dangerous. And we have things that are less dangerous like Tysabri that are probably more effective.
You stated that relapse and remitting diagnosis often changes to secondary progressive. What causes that to happen?
Very likely is unchecked inflammation. So the more inflammation that goes on, the more damage that occurs. And then every piece of, early on you have a lot of resilience. You have a lot of, resilient or just extra capacity. So as the more damage gets done, after a while, every piece of new damage starts to become clinically manifest. In addition, the disease changes as well. So what happens is that even though it starts out with a macroscopic inflammatory process, what happens is that over time it changes and it doesn't really become degenerative, but it's become more of a microscopic inflammatory process. Why that change occurs over time is unclear, but that probably is one of the things that causes people to shift into secondary progressive.
Back here. Back here.
Lemtrada.
Yes, Lemtrada, go ahead.
Your opinions as to why it's been denied and whether you think it's going to get approved.
Okay, so Lemtrada, that was the drug that I talked about, alemtuzumab. So, yeah, Stuart, I'm trying to answer a question. That was, Lemtrada was alemtuzumab. That's the one that's given 5 days a year, 5 days a week for the first year and then 3 days the second year. So, the FDA said the trials were done incorrectly and they weren't properly blinded. And that's quite true. But that's probably not why they didn't approve it. The reason they didn't approve it probably has more to do with they're worried about the safety. Lemtrada is an effective drug. When you looked at it in head-to-head trials against Rebif, it looked a little bit better than Rebif, but not a heck of a lot. Okay, the relapses were affected better, but when you looked at the MRI, there really wasn't that much better. And then what you have is you have an enormous level of risk. So 36% get autoimmune thyroiditis, some of which may be treated. After that thyroiditis, there's an increased risk of papillary carcinoma of the thyroid. ITP can be deadly, okay? That's a disorder where your immune system makes antibodies against platelets, and then your blood can't clot and you can bleed to death. And then it can cause Goodpasture syndrome, and that oftentimes will require a kidney transplant, and it can be fatal. And then autoimmune hemolytic anemia. And then there's long-term immunosuppression. Okay? So when you look at this enormous risk pool, and you say, okay, is this drug appropriately safe to put on the market? And the answer is, I'm not really sure. I think in my hands, yeah, I know exactly what I'm doing. But, if this drug is available to a neurologist who gets a bug and decides that he wants to start treating people with alemtuzumab, he may be treating the wrong people. And, we've seen this over and over again with many other drugs. Also on alemtuzumab, once again, if it does get approved, and I think it should be available, but very restricted. people have to have their blood work done every month for 4 years, because these things can occur 4 years after the last dose. So, that it's kind of a scary drug.
Question here.
I'm back again. I have a question. What would you recommend for a medication with someone? I don't like that in my face.
I'm sorry.
I'll repeat the question. Go ahead.
What medicine would you recommend for someone that's been on Tysabri? It's the only medicine I've been on, and I have to get off. I'm JC positive, and I've been on it for going on 3 years. I have tumor-factive MS, and it's very aggressive.
Okay. So the question is, what drug would we recommend for somebody who has very aggressive tumor-factive MS, who's been on Tysabri for 2.5 years, and is JC virus positive? So that's a really good question. So right now, so basically you want to talk to your doctor about the options that are available. There's one option that would probably be the best option if I were you in a situation like that. And let me just come back to that and explain. Tumor-factive MS is a form of MS where the lesions are very large. They're so big that they don't look like normal MS lesions. They look like tumors, okay? So the drug that we use in this situation is a drug called Rituxan. Rituxan is not approved by the FDA, but sometimes we can get it. So sometimes the drug company that makes it will give it to us. And Rituxan is basically exactly the same as ocrelizumab. Ocrelizumab is the new form of Rituxan, and it's got a different name because it's different by a very tiny little bit. The reason being is that, Rituxan will go off patent, and then ocrelizumab will stay on patent. Okay, so that protects the drug company's profits, and they have to stay in business because only about 1 out of 20 drugs that makes it into phase 2 trials will even get to will make it through phase 3 trials. So, and they spend enormous amounts of money. It's really a very difficult process. But the drug would be Rituxan. And Rituxan decreases basically new lesions by around 95%. And when people fail Tysabri, because Tysabri is still not a cure, that's when we go to Rituxan. And so usually we have to really jump through a lot of hoops. But it all depends on the insurance situation and if we can get somebody with 2 brain cells at the insurance company to listen to what we're saying.
Would you spell it, please?
All right, we have a question in the back.
Wait 1 second. You spell it.
Oh yeah, Rituxan is Rituxan. You bet. Go ahead, question in the back.
Yes, Dr. Jeffery. I've been hearing a lot about compound pharmaceuticals, and I wanted to know, will they ever get to the level of the medications that are out there now?
The answer is about compounded pharmaceuticals, hard to say. So compounded pharmaceuticals, you have to be really careful. So remember a little while ago you were hearing about the pharmacy where people had gotten the steroid injections and got the meningitis. Those came from compounded pharmacies. They used to make 4-aminopyridine, and they still do in compounded pharmacies. The problem is that 1 month you would get a pill that had 20 milligrams. The next month you might get a pill that had 200 milligrams. That 200 milligrams is really dangerous. So in the compounded pharmacy, the real problem is you don't have any idea of quality control and you don't know what you're taking. So we want to really stay away from compounded pharmaceuticals. We're much better off going with the real thing. And then you know what you're getting. You've got quality control, and we have a good level of safety and comfort.
When I was in elementary school in 1960s, they had Latin language classes. How do you learn how to pronounce the medicines?
So you have to go to medical school for that. The only drawback is that when you get out of medical school, you can't spell anything.
If you have patients that are currently on Rituxan, would you switch them to the more humanized versions in 2016?
Not if I can still get Rituxan paid for. Rituxan is actually less expensive than all of the agents we have on the market today. So it's cost about $22,000 a year. And despite that, the insurance companies still don't want to pay for it because it's not FDA approved, even though there's lots of studies showing how effective it is.
You ready? Okay. I wanted to ask your opinions, your views on stem cells.
Okay, so there's two types of stem cell things going on. One is a mesenchymal stem cell, and this is a stem cell that might actually convert to a neural cell. They're in their earliest stages of study. In other countries, you'll see things where they're advertising stem cell transplants. That's not real stem cells. That's quack medicine. Okay. Especially in Costa Rica, Mexico, Russia, you don't want to do that because basically you might as well give your money to, the stranger next door. Okay. There's another type of a stem cell transplant, which is a bone marrow stem cell transplant. And what they do in there is they take a sample of your bone marrow and they isolate some of the nascent stem cells from your bone marrow. And then they basically kill your immune system and give you the transplant with your own stem cells and regrow your immune system. It's really, what the most effective part of it is probably all the chemotherapy they give you to kill your immune system. It's not something I would recommend. It's something where only in the most desperate situation would I ever, advise a patient to that might be a reasonable choice.
Okay, back in the back again first.
Jessica, are you feeling neglected? I have a question. At what age? I really agree with what you're saying about let your kids know and talk to your family. At what age do you think it's appropriate to start talking to your children or grandchildren about MS?
From the beginning. So after I had my son, the first medicine that I was taking was an injectable medicine. And it was, my son was so young, he had no idea. But I started by taking injections, not on purpose in front of him, but it was just kind of integrated at where I took it that he was sort of around. As little as he's been to MS walks, I encourage communication, even if it's just very simple communication. Say that you have a 5-year-old that you were just diagnosed and you have a 5-year-old. And so one of the tools that I use with my son is he has an anatomy book that he really likes, and he's not like super smart. He's a good kid. And I think I'm out of the space that I need to be in to talk. But he has this anatomy book, and in it there's a part with the brain, and it has like the myelin, and it talks about the function of the myelin. And I said, what's really cool is your myelin works super good. So your brain sends messages to your body and it works really, really fast. Where mommy's myelin is a little bit broken. And so when it's broken, it means that sometimes I don't get the same messages quite as fast. So it might take me longer to understand something or a little bit longer to do something. So that's a good example if you have like a child that's, maybe 5 years old or 6 years old, 7, explaining symptoms like how you experience them. So if you're so tired, you could explain, I know I just slept last night, but I'm so tired, like I didn't take a nap and I didn't sleep last night. That's how I feel. Or do you remember when we stayed up New Year's Eve and how tired you were? That's how I feel right now, because my body does that sometimes with MS. But the good thing is when I get some rest, it's like an energy bank account, and then I feel better, and then I'm able to do some things, and that's why it's good to rest. So that's kind of maybe for the 5 to 7-year-old. But my son is early. Don't let MS be a secret or a surprise. It's okay, and it can be safe.
Question here.
Jessica, you're going to be on a roll now. Kind of twofold, if you will, two questions. One, first, as far as like relationships, possibly, relationships with friends and stuff, where some things you might have to do differently, or things have changed, and you might be able to do one thing that time, but the next time you might have to say, you know what, I can't do it. So if you could just kind of speak a little bit about that, as well as in the family in general as well. Specific, I'm glad this woman had asked that question about when should you, tell children and stuff. How do you kind of educate as far as like your own family, like the importance of that? So say, for example, a niece and a nephew.
Okay. So,
Thank you.
So the friends thing. It's hard to describe some symptoms when they're invisible. And so I'm just going to put that out there, that it can be very, very difficult. Fatigue, one. So if for any females that have friends that are childbearing age, when they start complaining about their first trimester, say, double that. That's how I feel, because that's what fatigue feels like. For answering both of them, it starts with education. So educating your friends, bringing them to MS walks, giving them a little bit of information about fatigue. If they love you, they're going to want to learn a little bit, even if it's just a little bit at a time. And it's incredibly important for them to get that information so they can know what they know, and so they can support you in the best way that they can. It's really important to have an open dialogue with your friend and say, I need to remove guilt from myself. So if I tell you that I'm so tired that I cannot go to Bunko, I don't know if you guys know what Bunko is. It's like a dice game I play with my girlfriends. If I say I'm too tired to go to Bunko, in my heart, I am too tired to go to Bunko. So I'm not going to feel guilty that I told you, because if I told you I'm that tired. Does that make sense? That's that circle of trust sort of again. And then for nieces and nephews, I would definitely say openly talking about MS, not overly talking about it, but openly talking about it. There are some really great resources for children. And then I encourage you to bring them to events and be with other people that, have kids that have MS, or have, other nieces and nephews that have MS. Just integrate the acceptance that this is kind of a normal family. Did that answer? Yes. Okay.
Question here.
Hi. Hey, Jessica. It's Robin.
Hey.
Hey. So, first question, actually, can I ask three or just one? Well, one for Dr. Jeffery, one for Jessica, and then one for you. So, Dr. Jeffery, I think when you were talking about the stem cell, the chemo with the stem cell, was that the hematopoietic stem cell?
Yeah, that's the hematopoietic stem cell transplant.
Yes, I messed that word up. I'm sorry. But I actually have been monitoring an online community of social media community of MSers getting that treatment done, and they're getting the procedure done out of the country, and it seems to be going very, very well for them.
I would be very careful about that, because, the ones that are done outside of the country, unless, for the most part, if they're done like in Costa Rica or Mexico, those are not real stem cell transplants.
They're the ones being done in Russia, India, Germany, Israel, and now I believe Italy.
It would depend on which group is doing them. So what I can tell you is that there's a lot of quack stem cell transplants. The procedure is done in this country, and it's done as a legitimate procedure. It's done in the context of a clinical trial. There does appear to be some benefit in that inflammatory disease activity is greatly reduced following the stem cell transplant, but progression of disability is not reduced. And eventually, they do have recrudescence of inflammatory disease on the MRI, but it does slow things down for a period of about 5 years. Now, if they're done in another country, if they're done in Costa Rica or Mexico, I guarantee they're not doing a real stem cell transplant. If they're done in Germany, they may well be doing a real stem cell transplant. You'd have to look up and make sure that it's being done in a university setting. You also have to be very careful about what you get online, because, if you have your fake stem cell transplants in Costa Rica and you want a lot of people to get interested in it, you start posting fake message boards where supposed patients are talking about it a lot. So I'd be really, really careful. Even if we were talking about a real live stem cell, hematopoietic stem cell transplant, it's not something I would recommend. You would be much better off going with a standard therapy, because what happens is that once you've been exposed to those chemotherapies, they actually have permanent effects on your immune system. So anybody who's been exposed to something like Imuran or Novantrone, they have a much higher risk of PML than somebody who's never been exposed to that. And the effects are cumulative with each additional immunosuppressive agent that you're exposed to.
Mm-hmm. Okay. And then my next question is for Jessica. When you talk about talking to the family, I know that when I talked to my nieces about what was going on with me, because at that time I was very sick and I couldn't walk, they were visibly upset.
Mm-hmm.
So how do you manage that? Because even though I was kind of making it really light and really gentle, the fact that I couldn't go to the amusement park with them, like they just couldn't grasp it.
Unfortunately, sometimes MS can do that, right? It can rob great experiences with your family members and children. And sometimes you can't get by that your feet are not working or that you're not able to do something. And the best way I would think to handle that would be to be honest with them that you're having an active MS relapse, that your relapse is very angry. Child-friendly words. Your MS is very angry, and you're going to be working with your doctor to make it less angry. But right now, what it means when it's angry is that my feet don't move as good. My son knows when my MS gets angry, my foot can get a little bit numb. So we know that, and so we just have safe words that we talk about. But it can be very difficult. This is not an easy game. Living with MS, and when it's hard, sometimes you're in a difficult position. But being honest always wins.
Question. Dr. Jeffrey, what's your opinion on estriol and using it with another compound or by itself?
Okay, so there was a recent study presented just last week at the Academy of Neurology meetings, and basically it was very unimpressive. So it was estriol plus Copaxone versus placebo plus Copaxone. And, they seemed to show a decrease in the relapse rate, but when you looked at the MRI, there was no difference at all between estriol and placebo. And what that tells me is that basically there was investigator bias that brought about the decrease in the relapse rate. So I would not go anywhere near it. A lot of potential adverse events associated with estrogen therapies.
Question I have in the back here, but before I do, for anybody that's leaving early, please remember we need your seminar evaluation forms. So Jill's right here by the back door. If you're leaving early, please just drop it with Jill on the way out. Thank you. All right, question here.
Hi, my name is Lenny Peretti. I want to thank both of you speakers. My question is for Dr. Jeffrey. For secondary progressive, which is what I have, the medications that you spoke about that are coming in the pike 2016, is that geared up for that, or is there anything?
Okay, so people are looking at those drugs for progressive MS. Once again, we don't have a drug which is approved for progressive MS, but sometimes when we try to treat progressive MS, we really do a lot better than we think. So even back in the early 90s, I had one patient who had clearly secondary progressive MS, and when I started him on beta-seron, he stabilized out and didn't worsen for many, many years. And even then, only a little bit. I still see him. He's not much different now than he was back then, except that he's 80 years old. So even more recently, I treated a patient with secondary progressive MS very clearly, and I treated him with Tysabri, and it took about 7 or 8 months, but he actually got better. His strength actually improved and his walking improved. So just because we don't have a medication that's approved by the FDA for secondary progressive MS doesn't mean we can't do anything. We can.
Okay, all right, thank you. That's what I was going to ask you about Tysabri, which I'm not on, if that's something that would be considered for secondary progressive.
Absolutely. Anybody we would consider Tysabri for anybody with worsening MS.
Question here.
Okay, we only have like another 10 minutes of questions because it is getting late. I know a lot of people want to get out of here.
Yeah, it's 8:45 now. I'm going to turn into a pumpkin.
So I'm thinking 10 more minutes if you're okay with that.
Okay.
Yeah,
Well,
right.
I will assure you that mine will not take more than 10 minutes.
Go ahead.
But my question is, when you speak a little bit about remission, what is the potential for it to happen?
Okay.
What is the hope for that?
All right.
And
So
also,
let me-
when is it indicated for a patient to?
Okay, so what remission is, and this is probably one of the biggest misnomers. It sounds like when we talk about remission that people are better and they're back to normal and not having any symptoms, and that's not really remission. So remission is in between the attacks. So if, let's say somebody has a clinical attack, and let's say their right leg gets real weak, and let's say it gets a little bit better, but it's still weak and they have trouble walking, but then they're not having anything new aside from that leg weakness, that's considered remission. So remission doesn't mean that you're better, and it doesn't mean that the symptoms go away. So when people are in remission, they still have lots of trouble with fatigue, occasional numbness and tingling, memory problems, and we say they're in remission because their disease is not actively worsening during that time, but it doesn't mean they're better, okay? So that's what we mean when we say remission.
There's a study being done at Northwestern with stem cells. Do you have any opinion on that?
Yeah, that's the stem cell. That's the legitimate stem cell transplant that's hematopoietic that I think Bruce Cohen at Northwestern in Chicago is doing. And so I know Bruce quite well. We're good friends. They studied it, and they're among the ones who have published papers showing that, after about people still progress after the stem cell transplant, and after about 5 years, the inflammatory disease activity can recrudesce. You see, all that was based on the thought that MS is autoimmune. If MS is autoimmune and you drastically reset the immune system, then that should work. But let me tell you another story. So there's another type of a stem cell transplant, not a stem cell, bone marrow transplant, which is called an allogeneic bone marrow transplant. And this is done for people who have leukemia. And so what happens is that you take a person, you completely eradicate their immune system, and you transplant somebody else's immune system into them. And so you give them a brand new immune system. So if MS were an autoimmune disease, you would expect that to cure the MS. Problem is, it doesn't cure MS. So I've had one patient who I published who actually had leukemia and got an allogeneic transplant, and it cured his leukemia. That was gone, but his MS was still there, and he still had optic neuritis. And then there's other papers published in the literature showing that people who had brand new bone marrow or brand new immune systems transplanted still had active MS. So when you think, okay, why is that? Well, it really leads you to question whether MS is an autoimmune disease. And what it tells you, if there's something abnormal in the nervous system, any competent immune system will attack it. And I think that's what is happening in MS.
Okay, we have time for 3 more questions, and that's it.
Pamela?
Yes. Hey,
How are
great.
you?
Good to see you.
Good to
All
see
right.
you, too.
Question for you and a question for Jessica. Okay, Jessica, adults. You've been talking about language for children, but what about language for adults? When you talk about your peers or people in your immediate community, because especially when you talk about I feel tired, they say, oh, I feel tired too.
Yeah.
Hey, I feel tired too. Because they're not understanding which, I didn't feel washed. Oh, I feel washed out too. Mm-hmm. So what are some of the languages that we can get them to understand where you're coming from? Otherwise, you get frustrated with them. You say, oh, I'm just going to X you out and go somewhere else.
Okay, so my advice, one, to be funny, don't talk to them like they're kids. Don't use the other examples I had, but tell them my tired is not your kind of tired. And I wish you understood what I was saying, but my tired is not your kind of tired. Maybe if you can remember a time in your life where you had the flu and someone in your family member passed away, or just something where they had grief and something horrible happened, maybe it could be a little bit similar. But your tired is not the same. And it's okay to say that. It's okay that they want to identify with you and they want to say, oh, I'm really tired too, or I've had a long day and, I mess up words. but it's different. The best thing that you can do is what the best thing you can do for yourself is give yourself information, right? That's the best thing that you can do with living with multiple sclerosis is educate yourself so you're not scared and you know how to move forward. And the best thing that you can do for your friends is provide them with resources, with information in language that is okay for adults to have, which is what you have all around here, available to you. And if they love you, they're going to read it, and they may actually ask you what it's like for you.
And the other question is for Dr. Jeffery. And I know maybe some other people have asked this question, but when you taking MS medications, but you also prescribe to them steroids, and the safety in that. Because some neurologists say, oh, you can't do that. I'm going, well, my doctor does.
So the answer is, the safety about steroids. So when we treat a relapse, and this is kind of important, what happens in a relapse is you have new inflammation in a strategic location in your nervous system. And that inflammation is doing damage to the nervous system. Longer that inflammation goes on, the more damage you have. So what the steroids do, and really the only thing they do, is they shut down the inflammation. You stop the inflammation and you stop the damage from progressing. So the quicker you do that, the better, because it's much easier to recover from less damage than it is from more damage. That being said, steroids are kind of a pain. They have a lot of side effects. Most of them are pretty transient. You're only on them for 2 weeks. Okay, so it's not a long-term steroid, just for 2 weeks. So typically what happens is that most people want to eat everything in sight and everything tastes like metal and they can't sleep, so we have to give them something to help them sleep, and it upsets their stomachs, so we put people on Prilosec. Rarely, steroids can cause something known as aseptic necrosis. So in my patients, I warn them every time I put them on steroids that this can happen. And aseptic necrosis happens where the joint or the portion of the bone just kind of dies. And it can be very serious. If it happens in the hip, which is the most common location, it can require a hip replacement. The risk is about 1 in 1,000 to 1 in 2,500, but I do have people who've had aseptic necrosis, and it is no fun. If somebody has a history of aseptic necrosis, there is a drug that you can use which is called ACTH, and that will work like a steroid, although it's not a steroid, and it won't make the aseptic necrosis worse. The only problem with that drug, and the sponsor was here tonight, is that it cost about $30,000 for a dose regimen. Okay, so there's no earthly excuse for that price. And I've been quoted in the Wall Street Journal, talking about that. But that's the only drug we have that will work in place of a steroid.
Back here is a question.
LDN as an alternative medicine has been around for 1,000 years, I think, with a lot of pluses and minuses from folks.
So low-dose naltrexone, LDN, has been studied in a couple of double-blind clinical trials that were well-controlled. And you do a double-blind so the patient doesn't know, what that means is that the patient doesn't know what they're getting, and neither does the doctor. Okay, and then their biases can't possibly affect the results because they don't know if the patient's getting a placebo or the real thing, and the patient doesn't know if they're on the placebo or the real thing. So the two studies that were done in very reputable MS centers, one in Milan, Italy, and one in San Francisco, California. Both of the studies showed that patients who got the low-dose naltrexone actually had a little bit less pain and a little bit less fatigue, but other than that, it didn't do a darn thing. Okay? So that is the truth for low-dose naltrexone, and we were all very surprised by the results because we really didn't think it did anything at all until those studies came out.
I'm going to ask a quick question before our friend here of Jessica. Jessica, sometimes with friends you just have to say, "You're not my friend anymore," and move on, because you can't worry about what that friend thinks about, or even people in your family. You have to take care of you, and sometimes you have to cut the.
So silver lining.
Silver lining.
So where's the question?
Well, I guess I was making a point.
So a silver lining is it's true. So one thing you will get from MS is you will get to see the depth of the relationships that you have. You will find out who are your good friends, who love you, who accept you, who try to understand. Same with spouses and same with family members. relationships are messy. And MS at least can bring to the surface your positive relationships and your healthy relationships and your negative ones. And then you get to decide what you're going to do with them.
Get rid of the negative ones.
Okay, last question, I'm sorry. What are your thoughts on getting a CCSVI procedure?
Okay, the CCSVI procedure, that is also quack medicine. I would absolutely not get the CCSVI procedure. So since that came out, there have been multiple studies showing that it does absolutely nothing. Even when it came out, most of us in the MS community said this is a bunch of garbage. The reason being, there are people who have venous occlusions called a venous sinus thrombosis. They don't get white matter lesions. There are people who have neck surgeries where the veins in their neck are ligated. They don't get MS lesions. I mean, there's just a whole slew of reasons we never believed it to start with, and it was like the modern day snake oil. I told people, yeah, you're much better off getting your mercury fillings removed.
So thank you everybody for coming down, and for whomever still may have a question for one of the speakers, if you will send it to me by email, then I will forward it to whichever one it belongs to, and I'll have them respond directly to you if that's okay with both of you. Is that okay with both of you? Yeah. Okay, that's good. Remember, he said that. So if you don't get an email from him, he said that. All right, thank you for coming down. And next, we have those raffles.